are some individuals that can throw this statistic out at me, but what is the current statistic for how many deaf kids have an additional disability? On the low end, Gallaudet Research Institute says 42%, but many researchers believe that that's between 60 and 80% at this point. So that's part of this conversation as well, that we can no longer live in a deaf ed bubble because our kids don't live in the bubble, in the traditional bubble that no longer exists, right? So I'm gonna move us a little bit, is that okay? So Stacey already pointed to this one, but I'm hoping that these standards will change in the next 10 years because we're only 4.5% for behavior. And of those, there are 3. That's it. We say there are 3 things deaf educators need to know about behavior, that we need to know about ongoing interactions with deaf kids and deaf peers. We need to have opportunities for interaction with individuals that are deaf and hard of hearing. And we need to know how to teach our kids the appropriate use of interpreters. That's all we need to know, right? So as a field, we're kind of behind where we know where we're at in the field, but our practice is behind that right now, or the literature is behind that. In terms of managing the learning environment, which is also behavior management, it's all related to deafness. Cultural factors, knowing devices, some classroom management strategies, and then at the bottom, I love it, we do talk about that we need to know multiple disabilities, but not a whole lot of information on that. So that's kind of where we are, and I guess this is rhetorical questions, but that's what brings us here today, is what is our pedagogy and how can we change that? What are our practices? And let's try and expand our practices to understand how we can meet these, the true bubble. Let's just, because there's not this is a deaf kid and this is what we do with them. It's not that way for any disability. So let's learn some strategies and how to modify them because Lord knows they're not written for deaf kids, right? So let's try and modify what we know is an evidence-based practice to make it work for our kids. And we're going to kind of co-construct that today. Sound like a plan? All right. I threw some ideas up here. So I believe that our strategies include bicultural, bilingual. Have you guys read a whole lot about bilingual, bicultural strategies? They could have taken it out of deaf education books. It's pretty much the same. So we do a lot of that strategy. We do a lot of literacy and language. And we do, boy, do we do audiological equipment. How many of you are itinerants? So how much of your time is spent on audiological equipment? Most of the time, maybe? A lot, right? So we have to know this other little specialty area. But really, some of the things that we do consistently, what is deaf education, is that we do a lot of modeling, a lot of shaping behaviors, so taking closer and closer approximations to our expectation and rewarding that all along. We do a lot of prompting, and then of course we do language, speech, and listening. So I'm going to let Stacey talk about this.
So we're going to actually move through this rather quickly. We did a study in 2011 where we sent a survey to the teachers of the deaf in Illinois. And actually we presented this at IFE and got a little bit of flack because we talked about the study and didn't talk about the interventions. But we're talking about the interventions today. That's why we're going to move through the study rather quickly. We basically asked which evidence-based practices they were familiar with and which ones they were using. And where did we get those evidence-based practices from? We got them from the autism literature because we're focusing on DHH complex learners, more specifically DHH with ASD. And so let's take a look at it. The purpose was to identify current teaching practices and knowledges of those practices of both the deaf and hard of hearing and ASD fields. So we were actually looking at both, but believe it or not, we got a much better response rate from the DHH field than we did from the LBS 1 or LBS 2 field. So we defined our complex learner as someone, a complex learner is students who have a hearing loss and an additional comorbid disability that impacts communication and behavior. So when we take a look at why we think this is important, and we know that there is GRI data out that's a little bit more recent, but this is the data that was presented when we first did our study. There are over 36,000 children in the U.S. have a hearing loss, and is that a high or low number?
That's a low number. That's
Okay.
how many are reported to the GRI. How many of you, do you report from your programs to the Gallaudet Research Institute every year? Yeah?
Good.
Good, so Illinois is on track. There are many, many, many students in the country that's numbers don't get reported to the Gallaudet Research Institute, so it's kind of accepted that those are somewhat low numbers.
About 40% at that point where children with a hearing loss had an additional disability. One thing I think is interesting is when this data was collected in 2008, it was 1 in every 110 children had autism, okay? But it's 1 in every 76 deaf children. So the incidence of autism and deafness appears to be higher in the deafness population than it is in the typical population. And since that time, our ASD numbers have changed. Just this in 2012, they went to 1 in every 88 children, which means 1 in every 54 males. Pretty scary, I think. And that is data that they're analyzing, that they just finally analyzed from 2009. So I really think the 1 in 76 is probably low as well. Yes?
Do they have any studies that are ongoing or of why the increase? Because this is worldwide.
They do have studies on the increase. A couple of them I was talking about was looking at kind of like that preterm birth, not carrying our children as long as we need to carry them. So there's that issue with dendritic connections. They're looking into dietary components because we are, all over the world now, we are people who consume high amounts of calories with low nutrition. And it's kind of like, have you ever put bad gas in your car? And it kind of sputters, and if it's bad enough gas, you have to take it and have it pumped out of your car, put better gas in, It's kind of that same concept. If we're not feeding our brain, we are not growing our brain. So they're looking at food. And they're looking also at blood studies. You guys are familiar with how they actually didn't eradicate, but were able to very much lower the incidence or the prevalence of spina bifida, correct? Are you aware of that research the CDC did?
I am not. Go ahead, fill us in.
Well, over a 5-year period, what we were looking at is we had a lot of children being born with spina bifida, okay? And what they did is the CDC, in these epidemiological studies, they had all the blood from the women who actually had children with spina bifida. And after taking a look at that, they noticed that all of those females had lower levels of folic acid in their blood, okay? And so they were like, ooh, this is one indicator. So what they did is a small study where they actually increased women's folic acid and tracked them for about 3 to 5 years through pregnancies. And what they noticed is that actually the rates of spina bifida went down, okay? And it was strong enough for them to actually work with the ag producers who were producing wheat products, so that all wheat products in our grocery stores were enriched with folic acid. And we had that big campaign, about 12 years ago, that all mothers needed to increase their levels of folic acid, okay?
Drink orange juice when we're pregnant, right? I mean, that's where that came from.
Yeah, so we have all of this information that this works. Well, lo and behold, across the United States and in other developing countries, we actually found that those much lower rates of spina bifida were coming out, except for in one population, and that was the Hispanic population, okay? Why do you think it was not lowering in the Hispanic population?
It's corn instead of wheat.
it's a corn-based diet instead of wheat. So we immediately went in and started enriching corn products with folic acid. And so our rates of spina bifida are lower than they've ever been, okay? So the CDC is very much looking at those dietary things. What are we low in? What's happening? What could be stopping those connections? There's also that genetic component. We know from the very first research that was done in the 1940s that 50% of the parents that were a part of those studies in both Asperger and Canner had some of the characteristics that the children exhibited. So we think that there is a genetic predisposition, and then there's something else that flips that switch. Very similar to, everyone says everybody has cancer living inside of them. It just depends on if the switch gets flipped, whether or not you grow it. Does that make sense? Does that help you understand kind of where we're looking at right now in the research? They also feel that because of the dietary issues, our human genome has changed, not for the better, but for the worse. Okay?
Okay. Sorry, we'll do this all
We are
day. We'll just be
we are
responsive.
research
We will
geeks.
be responsive to questions, and we'll get to what we get to.
Okay,
here.
so let's move on. We took a look at, in Illinois, we're a non-categorical state. You guys know that. The generalist is the LBS1. Then we have DHH and blind low vision. And then, do you want to talk about the training?
Yeah. How many of you are Illinois State grads? Yay! Here's what we found out when we looked at DHH programs across the country. I'm really fortunate because I have experience with 3 out of 6 of these programs, but deaf education across the country does not have courses in behavior or special ed or academic or social interventions. Illinois State does. And those of you who went to Illinois State may remember that we have a core of classes that everybody takes together. So we do, like you're in there with the special ed majors and the vision majors, and it's our, 101 or something, 201, 202, 203, 204. So our deaf education majors are in those behavior classes, and they're in affecting and changing behavior outside of deafness. Like we teach that within our program. There are only 6 in the country who do. So in terms of deaf ed on a national front, we aren't preparing for interventions outside of deafness. We're lucky we do have one program here in Illinois that has those courses, specific courses related to behavior. Multiple disabilities, yeah.
Okay. From a practitioner standpoint, this is kind of where we go, where we flop back and forth. The initial assessment and diagnosis drives the instructional practices that are delivered.
So if we find out that a child is deaf or hard of hearing, they are typically placed in that environment. If we find out that a child has autism, then they are typically placed in that behavior communication environment. What do you think happens when a child is very young and they may have autism? What do you think the parent initially thinks? That they're deaf, okay? Because we have a population, 2 populations that actually exhibit some of the same behaviors, okay, early on, all right? So that gets a little confusing right there. Which way are we going, right? We have to know the population is changing, and as teacher educators, we are still compartmentalized. We're very compartmentalized, even though our DHH students get those core classes.
They don't think it applies. Okay, I mean, does that surprise you? They're like, this isn't deaf ed.
If I have them in my applied behavior analysis class, they want to look at increasing a language behavior, which we used to let them do for a long, long time because I was being forced by my administration to let them do that. Now, they're doing behavior. They have to locate a behavior and change a social emotional behavior as opposed to that. And deaf education is considered a different degree, yikes, than a special education degree. And students in DHH sometimes feel as though the Common Core doesn't necessarily apply to their field. And that's probably us. We need to do a better job. Wow, I wish we could fix that. Yeah, I think the bulb's going to go on us.
Speaking of overstimulation and visual, right?
Yeah.
Yo.
I think we as our instructors in the field, we need to do a better job at telling our students, look, this all applies. Okay?
Okay, so probably several of you took this survey. Did anybody in this room take this survey, or are we? A couple of you? So we sent out a survey and we put the 11 established treatments from the National Autism Center's report, and we asked if, as Stacey said before, if they were familiar, used, or felt like it was meaningful to your population. One of the things to know that in 40 years in deaf education, so in 50 years of autism research, they've 11 established scientifically based evidence-based practices. Well, John Luckner did a study and looked at 40 years of deaf education literature, 964 articles, and only 22 of them were considered research. In that, they have a control group. There was enough for it to be generalized and to actually be called an evidence-based practice. And they were all literacy focused, right? And so we're really shy on the evidence-based practice end of things, where the National Autism Report reviewed 50 years, 1,060, and 775 of them were considered research. Now, not to dog on my field completely, why is it that in deaf ed we can't do that as well? Absolutely. We are a very small population, so getting the numbers to be scientifically valid aren't necessarily there. Absolutely. So when you look at deafness, there's hard of hearing, there's cochlear implant, there's sign users. I'll just say for my dissertation, I had to travel 600 miles just to get 3 subjects because they have to meet the same, right? They have to be the same degree of hearing. They have to have the same sort of programming. I had to live in 2 different states. Bye, baby. Mommy be home later. Because it's so hard for us. Our numbers are very small. So that's one reason. Are there many deaf education faculty members? No. How many of you went to a program with 1 deaf ed faculty member? Right? Or 2, maybe? There aren't very many deaf ed faculty members, and so it's not like we have time to run out and do research. And we're doing the important stuff. We're teaching teachers, right? And so there's a lot. And the other piece that John Luckner talks about is we are a very emotion-driven field, aren't we? We are so emotional. We're more emotional than any other field I've ever come in contact with. And so we have to pick as researchers, okay, well, am I working with a signing population, yes or no? And that determines where I submit publications to. Right? Because we're emotion driven. We are. We want to see our kids succeed, and we're very, very much a spectrum. So here's what we found, and this is very encouraging to us and scary and probably true of your caseloads. These are the disability categories that Teachers of the Deaf in Illinois worked with. All 13. There is not one disability category that you all are not working with. Is that true? This goes into that whole, it can't be a deafness practice. We're covering every single disability in this state. But we see them because we're the one that goes with them, right? Maybe for 12 years, they're on our caseload, but they also have all of these other disabilities. Look at autism. Over 60% of the teachers that responded to this survey are also seeing kids with an autism spectrum disorder.
That lets us know that prevalence rate within the deaf population is also higher when we look at that number alone.
Multiple disabilities. Thank you. The question was, what is MD? It's multiple disabilities.
I find that a lot of times they don't want to diagnose the autism because they're deaf, and then they a lot of times, even when we did before have an autism department that came out, they'd be reluctant to sign that. I'm in Chicago, but like now we don't even have a department. But even when we did, when they would come out with specialists, they would still say, well, you know, they're not comfortable because they feel like the communication and that. So I don't know, because I'd be curious what the percentage, like I have students that I would say are, but they haven't been officially diagnosed.
Right, now the diagnosis is very difficult. Give me a show of hands here. She said that oftentimes when you have a student who you think might have an autism spectrum disorder, there's reluctancy there for diagnosis. Anybody agree, right? And this is part of what I said before. There's a real, it's not, sorry, no offense, Stacey Bock, autism isn't palatable. If a parent needs to choose, not to just go with me here, is my child going to be labeled deaf and hard of hearing, or is my child going to be labeled autistic? What are they going to go with? Deaf and hard of hearing, right? But it's the whole problem with labeling and the whole issue, but we have to go there. That's how we get services, right? But it is very difficult to diagnose individuals who are deaf with autism. It's very difficult. I worked at Children's Hospital in Cincinnati. I work in the autism clinic there. And we have many students that are deaf with autism that go to the clinic. And it took years to get that diagnosis. And part of that is that overlapping triad of impairment. And so it's very, very difficult.
Yes.
How did we do it? And this is the whole thing that comes up in only our field. Swear to you, it's only us in vision of what's the primary educational label, right? This is where we go because that's going to determine the services that you can provide for a student. And I can't tell you how many IEPs I sat in when they go, well, deafness isn't the primary issue going on here, or well, autism's not the primary issue going on here, and you fight back and forth, and this is why these kids get moved from this building to this building to this building to this building, and it took years to get those kids diagnosed, and it was by a developmental pediatrician that knew deafness and autism. I was fortunate to be in Cincinnati where there's an entire team of people. It's in Cincinnati and she's fabulous. Her specialty is that. So I still do a lot of work with her. But I think that there is a lot of communication that has to happen. It is very difficult, but it is primarily going to come from a medical side for a dual diagnosis. Would you agree with
It's going
that?
to come from a medical side, but you're also going to have a team because you have to look at the impact of the disability on the child's ability to interact with the environment and learn. So is it the autism that's interfering more, or is it the deafness that's interfering more? And so that's why I think you need that team approach.
The other thing we're seeing is some of our kids that we've done this before, they're also Hispanic.
Yes.
So they're not willing to rule out it's the Spanish culture, it's the Spanish-speaking family home, so now you're stuck with Spanish-speaking family, possibly autism, definitely deafness, and nobody's willing to rule that piece out to say this is an autism.
Right. And I guess that this is only going to become more commonplace. And I know that. I'm seeing lots of nods. I know this is true, that we're going to have more and more English as a second language students who are also exhibiting multiple factors from multiple disabilities, which makes it very difficult.
The families that have the ability to take them to a doctor in Cincinnati to get them.
Absolutely. And those resources aren't there, and that's part of why I guess our passion is to be here. Because it's not necessarily what is their primary label, because I guess my soapbox that I'm going to step on for a minute is we got to learn the practices. There are kids, period. There are kids, they're deaf, they're complex. We need to call our colleagues in special ed and say, holy shnikes, I don't know where I'm going with this kid. I've got this much. Can you add your part? And together we decide what to do for this kid. Stacey, tell me about an evidence-based practice. Oh, let me tell you how to change that for a deaf kid. And that's part of what, if I could change the world, I would want to say, because I could say to a deaf educator, don't kick them off your caseload because they're complex. Work together to solve the problem. Because the one thing we know is that specialty piece. We know the deafness piece. I'm going to tell you guys about a kid that I saw last week in a little bit, deaf with autism. And the whole kicker was that he's got autism and he got new hearing aids. Okay, everybody just went, ooh, yeah. It's not because he's deaf that that's the issue. It's because it was a whole new auditory input and he couldn't stand the way that sounded. And so all of a sudden, this kid who's been a happy-go-lucky moving along in his curriculum for 3 years is freaking out in the classroom. And he's great. He's very verbal. He'll say, it's fuzzy, it's fuzzy. He can't stand that new hearing aid. And so now I say to the deaf educator, step out of your, let's get that hearing aid checked by the audiologist. This isn't an equipment issue. This is a normalization autism sensory issue. Does that make sense? So, I don't know, I'm going off.
Without the diagnosis, I think the biggest thing that I see with like just thinking about the few kids that I would definitely say are on the spectrum but don't have a diagnosis, that they end up getting services, they say then because they're not progressing. It makes sense with what you said early on, is that language and that visual, that needing of that, the sign isn't enough because it's gone so quickly, but they end up presenting as, well, I think they got a learning disability.
Right.
Or they're EMH or their son, and all of a sudden, but you got to, when you're working with that kid, the approach should be different if it's autistic as opposed to LD or EMH. So that's where because I have a couple kids in mind that teach that, well, there's something going, and then when the psychologist tests them, they're not coming up with LD, because they, on a one-on-one, without the distractions, they're able to perform, and then they say no, and then the teacher's mad with the psychologist, then the teacher's complaining like, well, I'm telling you that I've gone over this stuff, and this kid is not, making the academic gains that they should be. But you know what I'm saying? So it's like back and forth, and I'm a social worker, so I'm like, then they come to me and they're like, then I can't figure out, and then the kid's having behavior issues, but it's a result of this sensory it's not the learning, I guess.
Exactly.
Sure.
Let me tell you a funny little story from my side of the line. I worked with this child from probably 4th grade to junior in high school, okay? And he always had a space issue. Do you know what I mean?
Yeah, we're friends
Literally,
like that.
right up against you, just like this.
I'm a pro.
And so what did we do as behaviorists? We were like, okay, teach him the bubble, have him carry the hula hoop, put your hand back, and he would come closer and closer, and we'd be like, nope, nope. We kept pushing him away and pushing him away. Well, we're talking in 6 years, right? We're working on this, and we're thinking, you know what? He's just going to be a close talker. And we're not going to get this fixed, right? We've got an issue here, and we're just going to have to let everybody know in his environment. Do we put a sign on him? I'm going to get real close. That's okay. I'm not going to bother you. Or I may bother you, but I'm not going to hurt you. We find out junior in high school, he is profoundly deaf in one ear, and he's very hard of hearing in the other ear. And he has autism, and he loves ice cream trucks. However, that was why he kept coming up.
Right? Yeah. I mean, we all know that from the deaf strategy, but because the autism was there, it presents differently.
So I have to say, on our side of the line, we mess up too, okay? We were working on personal space when all along he needed hearing aids. So it's very hard, it's very complex, and we're not saying we know everything, and you guys aren't saying you know everything, but I think if we bring ourselves together, we're going to get much further. Okay, what is our time frame right? Does anybody need a break?
Yeah.
Are we there
Take
yet?
a break.
It
It's 11.
is break time. Well, before we start into some interventions, let's go ahead and take, you said a 15-minute break. We're going to take a 15-minute break so you guys can get up and move. And by the way, somebody turned on the heat. That's a beautiful thing. All right, so we will see you guys back here. at 11:15.